Worldwide Hospice and Palliative Care Day falls on the second Saturday of October every year. With the goal of promoting and supporting hospice and palliative care around the world, the designated day's theme this year is Palliative Care Because I Matter. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing a problem associated with life-threatening illness. A year ago, the Chinese government, for the very first time, officially published guidelines mapping out the standards and provisions for the administration of hospice and palliative care. So what changes have happened in China since then? How does palliative care in China compare to other countries, and why is it important to honor palliative and hospice care with a special day? Welcome to a special edition of The Point with me, Liu Xin. I'm pleased to be joined in the studio by Professor Ning Xiaohong, Associate Professor in the Geriatric Department of Peking Union Medical College Hospital in Beijing, Professor Deforia Lane, Associate Director of University Hospital's Seidman Cancer Center in Cleveland, US, and Professor Jennifer Phillip, the Chair of the Department of Palliative Medicine with the University of Melbourne. And before we begin the discussion, let's watch a video on Chinese people's thoughts on this issue.
Have you ever heard of palliative care?
Palliative care? No.
No. Like hospice care?
Palliative care advocates relieving the patient's pain and lets them die peacefully. For the terminally ill patients, should we try our best to expand their length of life, or try instead another approach to improve their quality of their remaining days?
It's up to the patient.
I support palliative care. It can reduce the pain of patients.
If there's no hope, we should try and help the patients die peacefully. I think this is right. But if there's a glimmer of hope, we should try our best to save their lives. From a moral perspective, we should try to save them. But if we can't save their lives, it not only makes the patient suffer unnecessarily, but also adds a burden to society.
Imagine one day you have a severe illness. Would you opt for living a bad life rather than dying a good death, or would you want to die with dignity?
I would choose to die with dignity, but if it happened to my parents, I wouldn't accept palliative care. I would try my best to let them live as long as possible.
Well, a variety of viewpoint, but the first thing, by the way, welcome to the show, ladies. The first thing that I noticed about people's answers to this question is the level or the lack of understanding or proper knowledge of palliative care. So, Professor Ning, may I start with you? Are you surprised? Is it uncommon for Chinese people to have little understanding about palliative care?
Yeah, I'm not surprised about this result. Because in China, we, even though we have known about the conception of end-of-life care 30 years ago, but in these 30 years, we have little progress in this thing. Only in recent years, more and more doctors and nurses and even the government began to know the importance of palliative care or end-of-life care. But the name, how do you call it? The people in the society, they are not so familiar with.
No.
But actually, they know this kind of thing. For example, how to treat those dying patients.
So exactly, you've already mentioned some names like palliative care, and then we have hospice care, we have end-of-life care. Before we discuss what these things are and how to do better, I think it is important to really help us understand what these terms really mean. Professor Lane, can I ask you just to give the layman a brief introduction as to what are the differences between all of these palliative care, hospice, end-of-life? Are we all talking about the same thing?
I think much of the time they're interchangeable, but I do think they are different. Hospice care definitely is talking about end of life. You might provide some palliative measures, but you are aware that there is a limited amount of time, and therefore we're more interested in the comfort of the patient. With palliative care, I believe it does end up more, you address the pain management of patients a great deal, and you treat the things that are going to give them the best quality of life. With end of life, I think that is kind of a big umbrella that that can mean multiple things. So the terminology is different wherever you go, and as is would be how people respond to it. Sometimes it's best to say end of life, and it doesn't scare as much as hospice or palliative care. So sometimes it's what people hear and how they respond.
Yeah, but is there a time limit we're talking about? For instance, when we talk about end of life, is there 6 months that we're talking about, 1 year? And are these people necessarily suffering a fatal illness? Professor Philip?
It's interesting that we're struggling with the terminology, and it's not surprising to hear some of the viewpoints that we heard on the video. I think end of life is a very flexible sort of thing, and it's interesting. In Australia, actually, end of life has been adopted by government more recently to encompass the last 12 months. So some of the clinicians that I work with would think that end of life is really, you know, the last sort of few weeks, and perhaps even less than that, maybe the last few days. But because of other layers of complexity and legislative thing, I think that adds to some of the confusion. Sometimes I think it's actually better, particularly when I'm talking to patients, to just describe the activities that we're talking about rather than the name, and then that's, you know, everyone can relate to the activities.
Okay. What would you say? You will reduce their pain, you increase their level of comfort?
Yeah, so pain and symptom management, as you mentioned in the introduction. I think that there's a lot that we do in palliative care around explaining things, explaining about what the illness, what the likely course of the illness is, having discussions about the future.
What is the prevalence of understanding or the awareness of to this issue among the Australian population?
So in Australia we also have a lot of misunderstanding around palliative care. There's a bit more, there's a few more people now who have heard of the term, although many people still haven't. But those people who've heard of the term, many of them have misconceptions around what it means, and some people think that it's an either or, that you either have treatment or you have palliative care. And
but it shouldn't be, it's not like that.
No, no, it can be, you know, in Australia, for example, we can deliver cancer treatments and palliative care at the same time. So that's sort of the thing that we are trying to explain to the people who will benefit.
Who finally come up with this suggestion? I mean, do the family member, because the family member don't want to give their beloved ones the impression that they are giving up on them, and the doctors don't want to do it. Who should decide? Professor Ning,
I think
it's a tricky question.
In China, I think it's the biggest problem. No one wants to talk about this thing, and for the doctors and nurses, they do not know how to talk about it. So they have to do what they are good to do. They can treat cancer, do surgery, but they know the patient is dying. They do not know how to say it, talk about it with the patient.
Have you had this kind of experience? How did you approach it?
When I'm young, I'm similar of them. But now, I feel it's a doctor's very important job to talk about the end-of-life thing with the patient and the family. So you ask who? It's a doctor.
It's a doctor.
Yeah.
Okay.
All the nurses.
Okay. And the patients, they are more able to understand the accept the decision.
Actually,
now?
most of the patients, they know about themselves very well. They know I'm not good. I'm going to die. But nobody talk with them about this in detail. When you talk with them, they are not, for example, surprised. No. They want to get suggestions from you.
Yeah. So what do you think that since the beginning of last year, the Chinese government rolled out systematically guidelines mapping out specific standards and provisions for palliative care here in China? Is the timing all right? And since then, what changes have taken place?
When the guideline came into, was born, doctors like us, those doctors who are very interested in the palliative care thing, we are very happy about that. Oh, great! The country have know the importance of end-of-life care. But as for the guideline, actually we do not read it on our daily life. But it is very important.
Why do you not read it in your daily life? Because it's too much.
It's too long.
Too long. Okay. Too high up there.
Too long.
Or
and too many words.
Or too detached with what you're doing on a day-to-day basis.
Actually, it's not. It's some kind of detached. Because for the doctors in different departments, they need to do different things. For example, in a cardiologist or in the renal department, they do not need this kind of thing. But for those doctors working in the oncology department or the geriatric department, actually they need a lot knowledge from this. But they do not know there is a guideline. So yeah, they do not know. And even they know, they say, I do not need it.
So nothing much has changed, or
change a lot. I want to say, even though doctors and nurses do not read the guidelines so often, a big change in China is that the government have choose 5 cities, 5 spots to try to practice palliative care things in that small area. So from the end of 2017 till now, they are in Shanghai, in Beijing, Chengdu, Changchun, and Zhengzhou. 5 cities. They have 5 spots.
As trials.
Some kinds of trials.
Some kind of trial. So these are actually so-called centers, palliative care centers, right? Where what are these facilities? Test spots. And if I understand correctly, that these facilities should be equipped with at least 50 beds, and that there should be at least 1 doctor, 4 nurses, and 12 caregivers for every 10 beds. So, meaning, you have to time everything by 5 there. So, is such hardware the kind of right recipe to address the problem that we're faced with here?
I think hardware is not so important. Even though we do not have so many beds or so big a space, the conception in our mind, especially in conception understanding of care in the doctors and nurses, is the most important thing. So hardware is not so good, so important.
Okay.
Education.
Well, we're going to take a very short break, and when we come back, we talk more about that, the software in improving palliative care here in China. And you have been watching The Point with Liu Xin. Stay right here. So welcome back to this special edition of The Point on palliative care in China and around the world. Professor Ning, you were talking about the weak point of software in improving China's palliative care. What exactly do you mean?
Software, I think, is the education to the doctors and nurses. We do not need to have a special place, but even in the hospitals, in different departments, those doctors and nurses who are taking care of dying patients, they should know how to give those patients a good death. In recent years, especially in the last 1 year, more and more doctors and nurses, they know about this conception, palliative care. They try to learn more things in different way about.
So it's not a separate discipline. It's basically any doctor who are treating patients with diseases, they might face the same challenge, right? Professor Lane, what do you think of that, and also hearing what Professor Ning has said?
We understand the stress that this kind of work has on our physicians and our nurses, on any of the healthcare providers. So one of the things we do is to provide education in the form of in-service, little workshops or grand rounds, where we discuss those very things. The research done to how we know that the more stress on a physician or a nurse, the more likely of a medical error. We don't want that.
No.
So by giving them some of the tools to use to reduce their own sense of stress and to increase their comfort with talking about what they do. And as a music therapist, that's one of the things I try very hard to do, is to give a doctor a sense of what it means to engage their patient in something that is calming and helpfully reducing their pain.
Yeah, it's fascinating that you mentioned you are a music therapist and you are doing that for cancer treatment, as part of the cancer treatment. How come it started? Would you just briefly touch upon that and maybe show us a little bit the magic of music therapy?
My journey with cancer patients began with my own journey as a person diagnosed with cancer, and I sought treatment at the hospital where I now work, but also where they had never had music therapy. Most recently, the National Institutes of Health and the Joint Commission, which is the organization that provides guidelines for all hospitals in order for them to be certified in the United States, they wrote into their guidelines the necessity of having non-pharmacologic treatment for patients, period. But patients in palliative care and in hospice, it's even more. So rather than thinking only medicine, only pharmacy, we can think broader than that. Education, but also something like music therapy, like relaxation techniques. And we found those to be significantly beneficial on the patients.
I can imagine, I mean, when you have music, right, it changes a person's mood, it changes the atmosphere, it's magical. Would you want to show a very short piece here, maybe?
One of the ways that I try to reduce patients' pain or offer them is to ask them, if you could write a song for someone, for whom would it be and what would you say? A little girl, unfortunately not having much time to live, and she wanted to write a song for her nurse, which she did not particularly care for. And the song was, "Yucky needles, enemas, they make me want to shout. They're always watching what I eat, but what goes in comes out. If I could change one thing about Nurse Kathy and Nurse Lynn, I'd change them into coupons and then I'd cash them in."
Wow.
So and that's from the mouth of a child, just
so
expressing them. Lastly, one woman wanted this song that she always heard her mother sing to her. And over my head I hear music in the air. Over my head I hear music in the air. She simply wanted them to know, I'm okay. I hear music, not the voices of this discord around me, but something beautiful. And music was able to do that for her.
Yeah, wow, I'm almost, yeah, it's so touching, and it's sad and beautiful at the same time, and more beautiful than sad. I want to know, how do the patients feel afterwards? I mean, what's the perception of this music therapy? How do people, I'm sure some of them will have left us, but how did they feel
at the time? Okay, so many things are going through my head. 25 years after I had sung to a particular woman in the presence of her family, and she did pass away, 25 years later, I saw her husband in a store, and he said, "Oh, I remember. Yeah. You sang." So, or a family who was very tense and watched their mother go from a tight, muscularly tension, to a relaxed body. They'll say, "This is the first time I've seen my mother relax or smile." Okay. So I think people think well of it.
they were lucky in a way, let's say, that they had a way to help them relax. Professor Philip, however, not every nurse, not every doctor can sing. I guess the great majority of the cases would look for help from medicine. What would be the practice in Australia? I know Australia does extraordinarily well. According to a survey, it's actually ranking number 2 in the world after UK in terms of quality of palliative care. What's the experience there?
I think, to take up on what we were talking about earlier, I think that there is a recognition, not necessarily across the board, but a recognition that this has got to be everybody's responsibility. This is not just, we have a palliative care specialty in Australia, but palliative care needs to be done by all doctors and nurses, because everyone's going to be looking after people who are dying. Not everyone can or should be specialists, but everyone needs to be open to having the conversations, bringing up and sitting with the difficult things, perhaps engaging our colleagues who have other ways of navigating these conversations. So I think that's an important thing that's been recognised in Australia, and it's chipping away. It's not across the board by any means, but trying to do that, because we really need to get our heads around this. We've got a lot of challenges coming as people are ageing and our population is ageing, and people will have illnesses from which, you know, some of them will be serious illnesses, and as part of being human, we are born and we live and we die, and we need to work out how we're going to care for people in a way that reduces their suffering.
I do want to say China has a particularly severe aging challenge. By the end of 2017, the number of people aged 60 and above reached over 240 million. That's more than 17%. That is, people say before we all get rich, we all get old already. So I guess for the palliative care community, it must be a severe challenge. What is the biggest obstacle here, and what are some of the China-specific solutions you and your colleagues are trying to carve out?
I think the biggest one is the education to the doctors and nurses. They should know what they should do, they can do, and then when they know, they can show this knowledge to the patient and family to help them. The biggest obstacle. I think...
is there support from the government to this initiative, to such initiatives?
Education?
Yes.
Not so many.
Not yet.
But even though the government have not do this thing, we doctors should, our society, some kind of thing, we should do this kinds of education program. Yeah, we do have a program that's supported by the Living Will Promotion Association and the St. Christopher Hospice Education Center. This kind of education program called COCA to educate doctors and nurses. So that's the obstacle, the biggest one. I think we need the support of the country and the government. The government should know not only its importance, but also how to give enough resource to this area. For example, those policies to about insurance to the special group of patients.
Yeah, will those patients who need this kind of care get any help from their medical insurance if they receive palliative care?
No difference.
No difference.
So yeah,
right
they
now,
have to be treated as those acute disease.
Does that also partly explain why people have less understanding or less
I think
willingness?
it's part reason, because it's it told us that the government or the doctors do not think there are difference between acute disease and end-of-life care. There should be big difference, so the policy should be different.
Okay.
Yeah.
So given the obstacle, given the challenge, what are being done more specifically to find out some China-specific solutions? That was my second
solution.
Yeah, finding creative ways. I do not know. Maybe musical therapy. I mean, something. People need to be comforted.
Yeah. I think we already find many directions for the solution of this thing. The first one is education.
Yes.
We must do education. And second is education not only to doctor nurses, but also to the whole society, to let the people, let all the people in society know there is a way, there is a choice when they are facing death.
Could I chip in?
Absolutely, please,
I'm
Professor
very
Philip.
interested in this obstacles issue because I think there's so many layers in this question, and I can't speak for China, but in many countries, and I suspect also here, what we were talking about at the very beginning is this way that we view death and the way that we view serious illness, and that we actually as a society don't really have a very sophisticated conversation around that and what the limits of medicine are, and that actually at those limits of medicine that can be a cause of suffering rather than an amelioration of suffering. So we need to really have a much better conversation in a public realm, and I am increasingly thinking that part of my job is to be out in the public space and trying to sort of have a public education campaign, which can then be supplemented by the educational endeavours and the government policy issues, because this is a really sort of high value proposition.
Absolutely.
You know, we are talking about better care for people and actually at a lower cost. So it's really a good thing.
Professor Lane?
Yes. One of the things that affected me most deeply when I was diagnosed with cancer was 6 sessions for, it was a support group for a bunch of us that had been diagnosed once a week for about an hour and a half. And we all gathered, and there was one topic per night. And I'll never forget, an acting company had gone to people who had been diagnosed with cancer and talked with them in detail about what their fears were, what their questions were, how they got along with their doctor, what did they want to know that they didn't. And they acted these little scenarios in front of us using words that had come in my head, and I wondered, how did they know to say that? So the arts, in that sense, brought alive all of those things that were churning in me. I heard a song that similarly addressed the same things, and the resolve that was wanted, that they were looking for. So I think the arts can play a part at this particular conference that has happened.
Indeed. It's a huge topic. I know we only have 30 minutes, so unfortunate, but I see that it's an all-society effort, right? The government, the civil society, the communicating with the public, the education of the patients and the medical staff. So it's going to take a long way, I guess, for palliative care quality to improve in China, but with the awareness, let's hope that things will get better. We'll talk about it again. Okay, so many thanks to my 3 guests, Professor Ning Xiaohong, Associate Professor in the Geriatric Department of Peking Union Medical College Hospital in Beijing, Professor Deforia Lane, Associate Director of the University Hospital's Seidman Cancer Center in Cleveland, US, and Professor Jennifer Philip, the Chair of the Department of Palliative Medicine with the University of Melbourne. And with that, we come to the end of this special edition of The Point with Miliu Xin. As always, you can follow us on Facebook and Twitter using the handle The Point with LX. Download the application called CGTN to watch the show on your mobile devices, or go to YouTube and look for CGTN The Point. Thanks for watching. You've got The Point.